Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Archita Goyal and Vineeth Amba. They're medical students, and today's Kevin MD article is What's Driving Medical Students Away from Primary Care. Archita and Vineeth, welcome to the show.
Thank you so much for having us.
Thank you
All
for
right.
having us, Kevin.
All right. So, Archita, I'm going to start with you. What led both of you to write this article and then talk about the article itself for those who didn't get a chance to read it?
Yeah, of course. So I'm currently a fourth year medical student at Tufts. I've always been really interested in policy and advocacy. I studied health policy as part of my undergraduate degree. And when I got to medical school, I knew I wanted to stay involved in that work. So after my first year of medical school, I actually did an internship with Dr. Wayne Altman, who is also our mentor and a co-author on this paper. Couldn't be here for the podcast today with us. But that's how I got involved with and introduced to Primary Care for You, or PC for You, which is essentially a bill that aims to reform healthcare by increasing investment in and access to primary care. So I spent that summer after my first year researching various aspects of this bill, building a website for it, and eventually testified at the Massachusetts State House in favor of the bill as well. I met Vineeth throughout this process, so he can perhaps tell us a little bit more about the bill and kind of what led to our article from there as well.
All right, Vineeth. So before talking a little bit about the bill, just talk us about the context you are aspiring to. Both of you are in internal medicine. I'm in internal medicine as well. I've been doing primary care for 23 plus years now, and it seems like there's always been a primary care shortage ever since when I was in medical school at residency. So, Vineeth, tell us about the context. Tell us about the situation about why something like this, why this bill needs to happen.
So the context for us starting out personally, Archita and I both went through our first, second, and third year of medical school by the time we had actually met. And in our training, we hear from our preceptors, from other physicians, even those in primary care, about how much they're struggling, how many tasks they have outside of clinical care, the burnout they're experiencing. And at many times, we were even encouraged to actually leave our pathway into primary care. So it's really that personal context that drove us into working in our capacities in this primary care legislative reform. But thinking even broader at a national scale, we know today 100 million people in the US do not have access to a primary care physician on a regular basis. We know more and more medical students and trainees are opting not to practice primary care. And even those who have hopes of entering primary care in residency often leave that pathway before they end residency. So it was all these contexts, or personal context, the national context put together, that drove us to working on this piece of legislation. And this piece of legislation would do three things. It would increase investment in primary care to aim to achieve 15% investment in primary care by commercial insurers by 2029, shift how we pay for primary care from fee for service to a more value-based care system, and then finally incentivize primary care providers and physicians to reform and innovate in their practices, whether that be improving teams, improving technology, improving social supports. So this legislation really had a triple aim that addressed many of the issues that Archita and I were seeing in our own training.
So, Vineet, I just want to get back to one thing you said. So, as you were going through medical school and you're going through your rotations, your primary care rotations, you actually had instances where these primary care physicians, obviously overwhelmed, actively told their students not to pursue primary care. Am I hearing that right?
Yeah, as wild as that might seem, yes, that is exactly what was happening. Luckily, I had a drive to enter primary care before I entered medical school. So I was able to have these types of conversations with my preceptors. But a lot of preceptors, 5, 10, 15 years in, were already experiencing the burdens of primary care practice.
So, Archie, as I'm hearing kind of the highlights of the bill that Vineet just mentioned in terms of increasing the investment and shifting more towards value-based care and increasing primary care reimbursement codes, some of that is already happening already, right? So, do you feel like we've made enough progress over the last few years? Because each of those things is already in motion to some extent.
Yeah, that's a really good question. I think there has been definitely a shift from, trying to go to a value-based care model from fee for service. We hear that a lot of times, but the main difference in this is reshifting the focus to primary care itself. Because a lot of times when we talk about value-based care systems, they don't really focus on the shift to primary care, increasing investment in primary care. They might focus instead on specific specialty practices or how hospitals are run, but not necessarily the primary care practice itself, which is how this bill is a little bit different. And I think the reason that it's important to focus on primary care and how this idea came about is because essentially health starts at the primary care level. When someone comes into the doctor's office and they have complaints, the primary care doctor is the first one that sees them and addresses all of these things that are going on. And the goal is, of course, to never have these people end up in the hospital. You want to take care of their health right away and prevent future hospitalizations, future events. And so I think our bill and this investment in primary care is unique and different because it focuses on that first step, giving providers the resources, giving primary care physicians the resources to have the time, to have the support, to adequately treat the people that they're seeing and not be burnt out. Because unfortunately, we do see a lot of primary care physicians right now who leave because they're burnt out, because they don't have the resources and the support to do their job.
So, Arthur, as you talked about your background, certainly in public policy, what makes an initiative like this different from the many, many other times that we've tried to improve and prevent primary care physicians from leaving from the prior efforts in the past? What makes this different?
Yeah, I think some of the prior efforts, and Vineeth can definitely add to this as well, but a lot of the prior efforts focused on retaining primary care physicians through programs like, let's say, loan repayment programs or increasing salary. And while those things are important, of course, I think we've identified that the core issues are more so in the organizational structure and support, which prior bills didn't target. So as an example, primary care practices can really benefit from having extra support, whether it be through working with community health workers, while it be working with MAs, while it be working with any kind of other resources that can help them speedline their process. A lot of the administrative burden that primary care practices face is not adequately addressed in past efforts. So I think past efforts really focused on one aspect of primary care, which may have been, loan forgiveness. It may have been alleviating the burden that way, but they didn't really focus on the more systemic issues of the actual support and structures that are needed for primary care physicians to practice appropriately.
This bill, in our opinion, is very historic because it's trying to accomplish three amazing tasks all at once. First, increasing their primary care investment and addressing those systemic drivers. We know from a study back in California that increasing our primary care investment improves patient satisfaction. It reduces unnecessary hospitalizations and ED visits. So we know that this investment can actually improve outcomes. We know from Rhode Island that's already taken steps to increase their primary care investment that it improves health information technology, the alternative payment models we have at our disposal, preventive screening tools. So when it comes to the systemic factors, the types of support that primary care physicians need, investment is a way to accomplish those aims. Next, it shifts from fee-for-service to value-based care. We have some evidence that value-based care can generate savings over time. And also, it lets us go back to a way of primary care that was meant to be primary care, a primary care that is relationship based at the level of the person and not at the level of the service. And then third, we incentivize primary care providers and physicians with the tools and financial resources to take on those innovative tools into their practice, like community health workers, mental health care professionals, and nutrition support, as Archita said. So this is really historic and different because we're trying to address all these systemic factors, pushing people away from primary care all at once.
Vineeth, tell us the perspective among your fellow medical students. I know you just finished medical school. What is their view of primary care? Because the traditional thinking from all of my interviews is that medical students have six-figure loans, and then the disparity in terms of the payments between specialists and primary care is so large that going into primary care sometimes isn't economically feasible for a lot of medical students. Is that line of thinking still valid today?
It's definitely still valid today. I'm sitting here as one of those people with six-figure loans, so I can talk to you from my personal experience. A lot of people definitely still choose their specialties as a result of the financial burden they have incurred, not just throughout medical school, but also undergrad and through their gap years as well. The other item that drives people away from primary care or drives people away from being interested in primary care is that there might not be as much exposure to the excitement of primary care. Primary care for me was exciting because I got to experience those relationships before I came to medical school. I was working in the AmeriCorps program, and there I was working in a free clinic and mobile health clinic where I had those one-on-one interactions in the community. Not as many people have exposure to those values in primary care, and again, that relationship building that you can only get in a field like primary care over time. So I think it's really those two, the lack of exposure to the exciting elements of primary care that you can't get anywhere else, and the financial burden that might be disincentivizing students from entering this field.
Vineeth, what's the status of the bill currently?
Yeah, so the bill is still being discussed in the legislature. It's been reintroduced in this current cycle. It's had a hearing that Archita was able to speak at as well. But right now, it's still in the deliberations process. The exciting meeting point that Archita and I had was I was working on the bill directly when it came to its implementation and the fine details, and Archita was doing the advocacy on the outside, trying to push it forward. So it was really there. That was our meeting point in the last year of this bill's iteration.
So, Archita, what was it like to testify and speak at that hearing, and what were some of the responses that you heard from legislators?
Yeah, it was a really unique experience. It was the first time I had ever testified in a setting like that. Very interesting because I think at the medical student level, a lot of my colleagues have the thinking that, we're just medical students, we can't really have an impact. There's no use of doing this kind of advocacy or policy work now. If we want to, we can do it later on in the future, later on in our careers. But this was the first time I had the opportunity to testify with two other medical students at the time as well, just about our perspectives on primary care from a medical student perspective, what we had seen in rotations, how we see doctors respond to primary care. And I specifically had researched a little bit about, cost savings that we can expect if we invest in primary care. And doing the research and delivering these facts, but also telling legislators our personal experiences as medical students and what we've seen and what we've heard was so impactful. And I think it was a pleasant surprise to see how receptive everyone was to this. I don't think we had a single person that day speak in opposition to the bill, which was very interesting. And I think it just goes to show the impact that we can have at any level of training in policy and the impact that combined movements can have on pushing a bill forward. Since then, that summer I was able to make a website for PC4U, which is PC, the number 4U.org, that has all the testimonies that were given that day at the legislation hearing. And it also just has basic aspects of the bill. And the unique thing I think about this and policy in general is that it can be digestible by any sort of audience. So if you are a medical student, you should be able to understand what's going on with the bill. But also if you're a patient and you're wondering, how does this affect me and how does this affect my life? That's something you can learn from this bill as well. Similarly, if you're already a practicing primary care doctor, you can learn about how it affects you. So overall, I think it was a really interesting experience, and it just goes to show that policy has lots of different ways that it can influence people's day-to-day lives.
So, Arshita, I think that one of the biggest things that I see is that specific with the transition away from fee-for-service to value-based care, a lot of hospitals still depend on that revenue pipeline that fee-for-service provides, right? In our current system where predominantly our payment models are fee-for-service. So how do you resolve that tension that's there? Like how would you get a wholesale shift towards a value-based payment system?
Right. I mean, I think that's a question that, has been debated and talked about a lot because even though there's been a lot of different value-based care models out there, there's a reason we're still predominantly fee for service, as you mentioned. And I think it all comes down to the incentives that we're providing for these hospitals to shift to a more value-based care system. And also, what resources do these hospitals and practices have? I think from a few studies that I've read just in general about, value-based care and the transition to fee for service, the issue is that sometimes hospitals cannot afford to have the risk that can be associated with shifting to a more value-based care model. There's a lot of instances where hospitals, they're already struggling to break even, and they're saying, well, if we shift to a value-based care system and we're unable to meet the quality metrics or the quality goals, then how are we going to stay afloat? How are we going to make money? So I think that that's definitely a part of it. I think part of it can also be attributed to the fact that there's just not enough education as well in terms of what is value-based care. I think value-based care is one of those buzzwords that's thrown around a lot, but within value-based care, there's a lot of different models that can exist. And that's also what CMS is trying to do with a lot of their pilot programs that they have to see, well, which one of these value-based care models can be adopted and has positive outcomes. So in terms of how we actually convince people to shift, I think there's two main ways we can do that. The first would be increasing education around what we're doing exactly. So in this case, we're increasing investment in primary care. And second is why does that matter, right? A hospital will say, okay, how does this impact us? Why does it matter? I think communicating to them that this actually results in long-term savings for you, for your hospital, because we're intervening at the primary care level. That means people will have to go to the hospital less. That means they won't need as many procedures. They won't need as many things to be done. And this results in long-term cost savings for not only you, the hospital, but also for insurers who are involved and other payers involved. So I think seeing the financial impact for insurers and hospitals is really important, but it can also be difficult at a primary care level because primary care is one of those things where it can take years before you see those savings because it takes years to track outcomes.
Today's Kevin MD article is What's Driving Medical Students Away from Primary Care. Now I'm going to ask each of you just to share some take-home messages that you'd like to leave with the Kevin MD audience. Vineeth, why don't we start with you?
Sure. I really have two take-home messages from my end. First, since working on this bill, I've always known that primary care was in a crisis, but seeing the numbers on this bill and seeing the numbers on the United States as a whole was very eye-opening for me. But it's important, I think, for both trainees and for physicians to not be totally pessimistic about what's to come. We do have solutions, we do have options, and most importantly, we have a passionate community behind primary care that wants to see improvements for our patients. So my take-home message is that there are policy solutions and policy levers, and that PC4U in Massachusetts, I think, is an excellent framework to accomplish some of our missions. And then secondly, medical students and trainees do have the power to attack some of the obstacles that our patients face. Archita and I, that obstacle that our patients faced was access to primary care. And we saw that working in advocacy, writing op-eds at Kevin MD, or testifying directly, working in the legislature, are not just items that Archita and I have done. Many medical students and trainees have accomplished such advocacy goals in their own issue areas. So being aware of what's available to you in the advocacy realm, I think is a great step forward for any trainee.
And Archita, we'll end with you. Your take-home messages.
Yeah, I think my take-home message, similar to Vineeth, advocacy and policy engagement is important at every single level, whether that is medical student, being prior to medical school, entering medical school, being a trainee, whatever stage that may be. Secondly, take-home message, I would encourage anyone interested in learning more about primary care or this bill, PC4U, to go to pc4u.org. There's a lot of information on this legislation. You can stay up to date on the bill, and there's a way you can sign up for our newsletter for regular updates as well.
Well, thank you. Thanks to you both for sharing your perspective and insight, and thanks again for coming on the show.
Thank
Thanks so
you.
much, Kevin.